Hi, and welcome to this 10-minute Tuts on an approach to dyspepsia, brought to you by the Dr. Coffee podcast. Dyspepsia is defined according to the Rome 4 criteria as any combination of 4 symptoms: postprandial fullness, early satiety, epigastric pain, and or epigastric burning, and must be severe enough to interfere with the patient's usual activities of daily living. These symptoms must occur on at least 3 days per week over the previous 3 months and with an onset of at least 6 months advance. On history, you want to ask your patient about any illicit NSAID use, about any gastroesophageal reflux disease, or malignant features such as loss of weight, loss of appetite, and constitutional symptoms. I really like memory aids to remember important themes, keys, and topics in medicine, and for that reason, I've come up with a mnemonic to help you in an approach to dyspepsia. Now, you might laugh, but if it makes you laugh, it'll help you to remember. To remember the alarm features for dyspepsia, think of your patient as being an old, skinny puppy. That is, are they older than 55 years old with new onset dyspepsia? Do they have a family history of upper gastrointestinal cancers? Have they experienced weight loss? Are they skinny? Now, this doesn't mean that they must be skinny, but that they have an associated weight loss of significant amount. Usually, we quantify this as more than 5 to 10% of their body weight over a relatively short amount of time, like 3 to 6 months. Have they had any GIT bleeding? And then the POPI stands for progressive dysphagia, odonophagia, persistent vomiting, a palpable mass or lymph nodes, and yellow. Is your patient jaundiced? All of these are the alarm features to worry about in dyspepsia. The next important component of your history would be if there's any pain and where the location of this pain is, as this might indicate possible organs of involvement. Pain radiating to the back may be a pancreatitis. Biliary colic due to cholestasis is usually referred to the tip of the scapula, and this occurs more if the patient is eating fatty meals. They might complain of retrosternal pain if they have gastroesophageal reflux disease or esophagitis. And we must always remember that a heart attack can have poorly localized pain. We should always consider that a heart attack might be part of our differential, or at least some angina or other forms of acute coronary syndromes. In other videos, we've discussed how gastric ulcer pain is typically worsened by food, whereas duodenal ulcer pain is relieved by food and exacerbated by starvation. In your examination of a patient with dyspepsia, remember to look out for features of anemia, possibly due to blood loss, jaundice if the patient has gallstones or obstructive jaundice, and Vercou's node if there is any hint of a gastric malignancy. On abdominal examination, take care to note any areas of tenderness on palpation, and also there's something called Carnot sign, where tensing of muscles occurs on palpation, which indicates that the patient probably has abdominal wall pain rather than visceral pain. So how to investigate a patient with dyspepsia? Well, at the bedside, you're going to want to do an ECG, an arterial blood gas, and you may want to consider adding a urine dipstick as well. In terms of laboratory investigations, you want to send off a specimen for a full blood count as well as a U&E, and be on the lookout for a high blood urea, because a high urea to creatinine ratio is typically specific for upper GI bleeds. Urea is a breakdown product of the digestion of blood, and so a high urea can be because the patient is experiencing bleeding in the GIT. You can also send off blood for a liver function test, a CRP, a CMP, as well as an amylase and lipase, specifically checking the function of the pancreas. In terms of imaging investigations, this will be guided by the location of the patient's symptoms and any pains they are having. In the case of a suspected perforation, always remember that an erect chest x-ray is the most sensitive way to look for air under the diaphragm. You also want to consider endoscopy like a G-scope, consider a barium meal, as well as abdominal ultrasound. Now, an abdominal ultrasound is actually the cheapest and fastest way to visualize what's happening with the biliary tree and the liver, because you're able to visualize the ducts and see if there's any obstruction or any gallstones there. So remember that sometimes the quickest and easiest way is the best way to guide your management of your patient. I hope you enjoyed this 10-minute Tuts on an approach to dyspepsia. If you did, hit the like button and subscribe for more. You can also find the Dr. Coffee podcast on Spotify, YouTube, Apple Podcasts, and Google Podcasts, and follow us on Instagram at Dr. Coffee ZA.